Welcome to the body imaging cases. This is a 45-year lady with fibromyalgia, Sjogren syndrome, and 19 kilogram weight loss in 1 year. CT was performed initially, and it showed a focal liver lesion for which MRI has been done for further characterization a couple of months later. You are provided with the CT, MRI, 4 diagnostic possibilities to choose from, and 4 ways of further management to choose from. So let us discuss the possibility of a simple hepatic cyst. Here we have a certain number of observations against the possibility of a cyst. First, the lesion is not very homogeneous on T2 weighted images. Cysts tend to be extremely homogeneous. The outline is not very sharp, and cysts are usually very sharply defined, as if drawn by a very sharp pencil. There is enhancement of the wall of the cyst, which is definitely against a simple cyst, and there is an enhancing component inside the lesion, a definite feature against a cyst. The ADC value is not as high as we expect from a cyst. The cyst should be like the fluid inside the spinal canal, and the signal intensity on the 800 B value is too high again for a cyst, which should disappear entirely at this B value. So the cyst is out, and let us explore the possibility of a hemangioma. A hemangioma is not a bad choice here. The T2 weighted, T1 weighted, diffusion weighted imaging features can be accepted for a hemangioma. The presence of a knob of enhancement here may be a feature of a hemangioma. But what is definitely against a hemangioma is the presence of a continuous rim of enhancement. This feature should alarm the radiologist that this may not be a hemangioma. Hemangioma, at the periphery of the hemangioma, is most of the time discontinuous. There are small islands of enhancement, but a continuous rim is an alarming feature. So a hemangioma is out, and there is one common feature in the provided images here against both the cyst and the hemangioma, which is the increase in size of the lesion on comparison of the CT and the MRI. Evaluation of the size of the lesion is very important in radiology, and it becomes more important if we are dealing with a lesion on follow-up. If you are reporting from a workstation, estimation of the size of the lesion is easy by measurement. If not, then you may need to assess the size of the lesion visually in comparison to recognized anatomical landmark or to the scale given to you, if this is available. In this particular case, if you look at the lesion and compare it to the aorta, you know immediately that it is smaller, whereas the lesion on MRI looks exactly the same. So there has been an increase in size. With small lesions, don't say, fine, this is a very small increase in size, we can ignore that. I'm giving here 2 examples of a small lesion of 6 mm and a big lesion of 6 cm, and both of them will increase in 2 mm increase in diameter on follow-up. The 2 mm increase in diameter of the small lesion will result in 137% increase in volume, and you can translate this to 137% increase in the number of malignant cells if you are dealing with malignancy, whereas the Same increase in the diameter of 2 millimeter will result only in 10% increase in the volume of the big lesion. The message here is twofold. First, don't underestimate the increase of 1 or 2 millimeter in a small lesion. This is a substantial increase in volume. The second message is to be accurate during measurement of the small lesion, because error in measurement of 1 or 2 millimeter is a big error in estimation of the real size of the lesion. And for this, I'm giving you this hint also, that with a small lesion, you don't measure in the original magnification. If you have a workstation, just magnify and then start to put your cursor, because an error, as we have seen, in the manual placement of the cursor of 1 or 2 millimeter will result in a substantial error in recognition of the real size of the lesion. So now that we have chosen primary malignant neoplasm or metastasis and disregarded simple cyst and hemangioma, based on the features we have seen and based on the increase in size in a very short period of time, we'll move to what to do. Follow-up is out. You don't do follow-up for a lesion that you are suspecting to be malignant. And also because you have done already the follow-up. This is a retrospective follow-up because there has been period of time between arrangement of the MRI for the patient to further characterize a lesion seen on CT. And during this period of time, the lesion has already grown. Upfront surgery is also not an option because hepatic surgery is a major surgery and should be based on more substantial evidence of malignancy. So the advice given to the treating physician here was to do PET-CT or to biopsy or to do both. And doing both has the advantage of targeting the highest point of uptake in the lesion to get a representative sample. But what happened in reality was something different. The patient was taken into her problem of rheumatology, the fibromyalgia and the Sjogren syndrome, and the problem of the liver has been ignored. The patient resurfaced after 1 year with substantial increase in the size of the lesion, proving its malignant nature. And during this period, there has been no primary that declared itself. So this points here to the possibility of a primary malignant neoplasm of the liver rather than metastasis. You may say that this does not look like the known primary tumors of the liver, the hepatocellular carcinoma and the cholangiocarcinoma, and this is right. This is a rather rare primary tumor of the liver, which is the neuroendocrine tumor. Neuroendocrine tumor affects the liver more commonly as metastatic when it is located in other sites like the pancreas, the lung, or the intestine. It has two diagnostic features which we see here. The presence of a solid and a cystic component in the same lesion. Please note here that the cystic component is not a central breakdown, but the lesion is divided into two parts. One part is solid and one part is cystic, and this is a feature of a primary neuroendocrine tumor. The second feature is the enhancing rim at the periphery of the lesion. There is diffusion restriction in the solid component of the lesion. And here we see the cystic and the solid components. And the patient has developed a fatty liver in the interval, because on the previous MRI, as we see here, the liver was not fatty. This is a feature that has been reported also in several case reports in association with neuroendocrine tumor of the liver, there may be fatty change. This is how the cystic and solid components look like on the ultrasound, and the uptake of the FDG on PET-CT at the solid part of the tube. The patient has been operated upon by right hepatectomy, and the diagnosis proved to be primary neuroendocrine tumor of the liver. Neuroendocrine tumor of the liver is a rare primary tumor, and the features of it are mixed solid and cystic central parts of the lesion and peripheral rim of enhancement. A lesion with a continuous peripheral rim of enhancement is unlikely to be a hemangioma. If measurement is not possible, the size of the lesion may be evaluated visually by comparing it to an anatomical standard. When measuring small lesions for follow-up, magnify the lesion to avoid manual error of cursor placement, and increase in diameter of small lesions means substantial percentage increase in volume compared to the same increase in diameter of large lesions.